Good afternoon, and welcome to Grounding Your Medical Device Security Program in Good Governance, a health system CIO Media Inc. production, sponsored by Siemens Healthineers and Medigate by Claroty. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the founder and editor-in-chief of Health Systems CIO, and I'll be your moderator today. We're looking forward to your participation. You can send in your questions or comments at any time in the Q&A box, and we'll take them later in the program. Just so you see how we're going to spend our time today, first we're going to go about 40 minutes with our main panel discussion featuring Jason Elrod, VP and CISO with MultiCare, Samantha Jacques, VP of Clinical Engineering with McLaren Healthcare, Brett Harris, Cybersecurity Officer for the Americas with Siemens Healthineers, and Ty Greenhalgh, Industry Principal for Healthcare with Medigate by Claroty. And then we will have our Q&A. So let's jump right in. Lots of great stuff to discuss today. Jason, let's start with you. Can you give us an overview of your organization and your role?
Sure. As mentioned, I'm Jason Elrod. I'm the Vice President and Chief Information Security Officer for MultiCare Health System. For those not familiar with MultiCare, it is a not-for-profit healthcare organization that's been caring for communities in the state of Washington since its founding as Tacoma's first hospital way back in 1882. So we are a legacy organization. We have 12 hospitals in our systems, and we've grown to be the largest not-for-profit community-based locally owned health system in the state of Washington.
Excellent, Jason. Thank you. Sam?
Hello, everyone. I'm Sam Jacques. I am the Vice President of Clinical Engineering at McLaren, which is also a non-for-profit healthcare system. I have 13 hospitals in the state of Michigan. We have the largest cancer network in the state as well. So we are also, just like Jason's organization, a well-run, long-term organization here to go ahead and serve our community. So,
Excellent, Sam. Thank you. Brett?
Hi, everyone. I think most people on this call will be familiar with Siemens Healthineers, or Siemens Healthcare as we used to be known. But if you aren't, we're a global medical device company with over 60,000 people worldwide. We make devices like MRI machines, and we also provide services to healthcare organizations like multi-vendor services and security services. I'm Siemens Healthineers Cybersecurity Officer for the Americas region, and I'm responsible for customer-facing functions like product security discussions and security services, as well as internal cyber governance.
Excellent, Brett. Thank you. Ty?
Super. Medigate by Claroty is enterprise-wide asset visibility and communications profiling on devices like medical devices, IoT, building management systems, and providing device discovery, vulnerability and risk management, network management, the ability to take all this information that we're seeing about the devices and effectively implement segmentation at scale, threat detection, lifecycle management, integrating all this data back into the existing IT security stack. Really supporting healthcare specifically. Medigate's always been a healthcare focused organization before it got purchased by Claroty. And I'm the industry principal, basically subject matter expert, but understanding the Dunning-Kruger effect. There is just so much more for me to learn here. These are very deep waters, and I'll tell you, I'm a longtime listener of the show, and I'm sure I'm going to learn even more here with this great team you have assembled.
Well, thank you very much, Ty. All right, let's jump right in. We know that medical device security is one of the issues keeping CIOs and CISOs up at night. In your opinion, why is that? Why is it so hard for IT professionals to get their arms around this challenge? And interestingly, how much of this is a technology challenge versus a governance problem? So, Jason, we're going to start with you. What are your thoughts?
Gosh, I think it's a. So I'll answer the first part there. Why is it top of mind, right? Why is it an issue right there? I think it's because it's vastly complex. I mean, we're dealing with things from complex ecosystems, regulatory compliance, legacy systems, rapid technology advancement, diverse vendor landscape, resource constraints, skill gaps, of course, the cyber threat landscape, visibility and management concerns, and above all, patient safety. So when you look at that, maybe just even that short list, it's crucial to have a multifaceted approach to medical device security that involves everything from policies, monitoring, training, awareness programs, but above all, close collaboration with vendors and staff to adhere to the highest security standards here. All that to say, it's non-trivial, and so we have to have a non-trivial attention given to it.
Would you say it's one of the top 3 things that you think about, Jason? Something like that. I don't know if you function that way with a list like that, but what are your thoughts there?
Everything has a priority, right?
Mm-hmm.
And if you ask everybody, like, what's your number one priority? This, and this is my next number one priority, and my next number one priority. And I'm like, okay, well, what's priority 1A or 1A1 to get down to that? So you can only have one top priority, one number one priority. I would say medical device security, medical IoT is in the probably top 5 for me organizationally right now. Just given its complexity and interaction with patient care.
Okay, very good. Sam, your thoughts?
Yeah, I agree with what Jason said, but I would also say I think the medical device world is very different from the IT world, right? And so the process to get a medical device approved into market is so much longer than it is for any laptop or server. And so just a fundamental basic knowledge piece is that the technology that we get to market today, if it's released today, it's probably been in development for 5 to 7 years, right, prior to this. And so the legacy technology issue is huge in the medical device world because we're not building on current platforms. And so I think, IT has a hard time getting their arms around that because they're used to a life cycle of somewhere between 3 and 5 years, right? We're getting new laptops, we're getting new servers, we're always on the newest version of whatever system we're on. Medical devices don't function like that. And so trying to apply the same techniques from a security perspective to something that doesn't function the same way IT devices do is inherently challenging, right? And so truly understanding how medical devices work, how they're approved, how they come to market, right? And understanding how that induces additional risk into our environments is incredibly important for our IT professionals to go ahead and get their arms around. I would say though, right, a lot of the issues that we have are technology problems, right? We're building on platforms that are not necessarily supported anymore. But I would say solving those issues may not be a technology problem. I would actually say that a lot of them are governance problems, right? Understanding and defining what risk is okay to your organization, right? And drawing a line to how to define and manage that risk, right? Medical devices may be seen as inherently risky, but if we've implemented compensating controls to go ahead and mitigate those risks, maybe they aren't in your top 5 for your healthcare organization.
So you mentioned that a different approach is needed because of the development time, 1 to 3 years for a regular IT device versus 5 to 7, and that requires a different approach. Can you tell me a little bit more of your thoughts around that different approach that will be more appropriate?
Yeah, to me, right, our organization is a very risk-focused organization, right? And so we really want to understand what is the actual risk, right, for that device on your network, right? So is it internet facing, right? If it's internet facing in our world, that is a big red flag because, right, anybody who wants to get into our network is going to try and hack into those internet facing items. And so we would take a very rigorous approach to anything that's public facing from a network perspective. However, if it's internal to your network, right, there are other things that you can possibly do to mitigate those risks. We can segment it, right, stick it on a VLAN. We can go ahead and mitigate whatever ports it's communicating on to try and reduce some of those risks so that I'm not using typical IT things like patching, right, to mitigate the risk that it has. But To be honest, right, I know we're talking about medical devices. It doesn't necessarily matter what's on your network, in my opinion, right? It can be a medical device, it could be an IoT device, it could be an IT device. Fundamentally, we have to understand that risk and address that risk the way that our organization wants to from a risk mitigation perspective, right? So I'm going to tackle the riskiest things, and I'm going to leave those things that are not inherently risky in the way that I go ahead and count and manage that risk. Does that make sense?
Yep, definitely makes sense. Brett, let's go to you. What are your thoughts?
I mean, I think Sam has hit on some really important points here. A big piece of it is that, like she said, medical devices are not like typical IT devices. And she named a few reasons why. But one of the big things I see is that IT can't deploy their tools that they use to manage security on these devices like they do with laptops and servers and things like that. A lot of times these are lockdowns, so you can't install any third-party software. You can't use those typical IT tools. And then that creates a gap between what IT can see and what IT can do and what needs to be done with a medical device. I think the other thing to think about here with medical devices is that the number one thing is clinical care and patient safety. So that's the priority. And if security gets in the way of that, then security gets shoved out the door. So really understanding the clinical context of the medical device, how it's being used, what the workflows are, and then bringing in security to support that is super important. So that is a governance technique that, you know, the organization needs to bring to bear with these devices. So yeah, there's a technology problem. Yeah, there's a governance issue as well. I would say that it's a combination of both, and technology is going to play a role in solving some of these problems. Like, again, Sam was talking about VLAN segmentation. Like, that is a technology solution to a problem, but you have to have the governance in place to say, this is what we're doing with these devices in general. Here's how we're segmenting. Here's what we're doing.
Very good. Ty, your thoughts?
Well, I agree with everything everybody's saying. It's you know, a lot of great information. I'll try to just kind of fill in some holes as I see them. You know, the traditional IT technology that's being used to identify and manage the servers and laptops of the world, they don't work well with the medical devices. And so what you end up with is, you know, you see something out there and it's an IP address, but you don't know what it is. And so if you can't see the devices, you don't know what they are on your network, it becomes very problematic in trying to manage what their vulnerability, what their risks are, what their criticality is, and how you should respond to any type of anomalous behavior on a device. So the traditional IT security tools cannot see the devices, which, you know, in my effect, or in my opinion, for a CISO to try and manage a bunch of devices where they don't know what they are creates a lot of anxiety. I would suggest from the technology and governance perspective that, you know, kick it back with a rhetorical question, which is which side of the scissors is least important. You know, you really have to have the good technology. I think that having the discovery tools to be able to see OT and manage OT medical devices, you know, it's the basics, it's the block and tackle, it's the NIST cybersecurity framework, the ID, AM 1, 2, and 3. You know, it's the first 3 steps, and whether it's the CIS critical security controls. You know, you need to know what your assets are. You need to know what your software is. You need to know how they're communicating, and without that, you're kind of flying blind. And then, you know, even if you've got the best tech, without good governance, you can't employ that and make, you know, leverage the data. So I think that you know, you really need to have both.
Excellent.
I think
All right.
Ty's brought in a
Go ahead,
really
Brett.
good point here about, I think Ty's brought in a really good point here about visibility. You can't protect what you don't know is there. And historically, you know, IT has managed this by installing agents on systems. And like I was talking about before, generally you can't install those agents on systems. So having technology like Medigate, where you can do passive detection and analysis of systems, gives you that visibility into the medical devices to be able to do that proper management.
Yeah,
I
very
do want
good.
to add one thing to this.
Yeah, go ahead, Jim.
There's three sort of categories here. There's technology challenges, there's governance challenges, and then there's that conjunction, right? The intersection of technology and governance. I always like that people say it's this and that. It's actually three things. It's this, that, and the conjunction. And so a lot of what we mentioned here are some of the technology challenges, right? On legacy systems, interoperability. Can we encrypt? Can we authenticate in a modern fashion these devices? Do we have visibility? And does that visibility give us the correct level of cyber threat detection and response capability? Often not. Governance, we have policy development, regulatory compliance, vendor management. You know, even if you're working in those components on what's in your system, who are the vendors that you're partnering with, resources, training, but that intersection, right? It's standardization. So how do I get the technology and governance structures working together in a seamless fashion? How do I get that working? And how do I manage that? And how do I fold that into my overall enterprise risk management? Because that's really what we're doing here is we're managing risk at the level of the organization in the context of medical IoT, biomed, these types of systems. And of course, continuous monitoring improvement. I mean, again, that's on both sides, on the technology and the governance.
Excellent, Jason. Thank you. All right, next question. Sam, we're going to start with you. Let's talk more about governance. IT security, and biomed/clinical engineering must all work together to manage medical device security and risk. What types of structures have you seen work well, which have not? Offer examples if you can. And then I just comment below that, you know, a lot of times you'll hear people say, well, it doesn't really matter as long as we all get along. Well, that's fine. But again, there is an optimal way to have things structured. So what are your thoughts there, Sam?
Yeah, so I'm one of those people that'll tell you it doesn't matter to me, right, where you report to. Fundamentally in my world, right, we all need to be pulling in the same direction in order for, right, safety and security to ensure, right, patient safety. And so, but I have seen a lot of different models, right? A lot of the larger systems have moved biomed under IT. And look at them akin to, right, a workstation management type of group, right? They're people who have wrenches and tools and they go and fix things, but they also need to understand software and security and access levels and vulnerability management and such. I will tell you, most biomed departments are slowly getting there. They have not adopted a very security-centric focus yet, unless you're part of a very large system. Most mid-size and small hospitals still report to other departments, right? So if you're really in one of the old school hospitals, you may report to facilities, right? Because that's historically where biomed grew out of. And so, right, the facilities group as well doesn't necessarily have that focus on anything software related or patching or vulnerability management. And so it's a real struggle. I will say, you know, if you want to jumpstart kind of the move of your biomed department to a more security focused, like I said, I have seen a lot of hospitals realign biomed with IT. I will warn you though, it is a culture clash when that occurs, right? So IT has a very different help desk, help end user mentality than biomed does, right? IT has a very, I'm going to help you remotely. I'm going to walk you through some issues, right? We're going to do it over the phone, where the biomeds generally have a, I'm going to go see and stand next to you while we work together. And so that can be very helpful for an organization to go ahead and bridge the gap between those two different types of cultures. It can make IT much more healthcare centric, and it can make clinical engineering more IT centric, right? Where you're focused on software and controls and things like that. So I won't advocate for that because, right, I've seen it work where they don't necessarily report to each other. My organization, I don't report to IT, but we managed to make it work. fundamentally, right, my take-home message for you guys is we all need to understand, right, what we're here for. And we're here for patients, and we're here for patient safety. So we all need to be working on anything, right, related to security that enhances patient safety, right? Cybersecurity is patient safety.
Excellent. Jason?
I love everything Sam said. ×2. There we go.
Yeah.
So
Anything
like,
else?
well, I will add some of the things. I think there's two components here. So one is we talk about governance structures here. So I think ensuring medical device security in healthcare setting, it requires a multidisciplinary approach. It's not just IT. It's not just IT security. And it's not just biomed or clinical engineering. It's all of them together. And yeah, I've seen various models, and a lot of them of sank or swam, all depending on the culture. I mean, that's the other point that Sam brought up. The culture clash has to be there. Everything from a centralized governance structure to decentralized, to hybrid, to collaborative, to Sam's point, service line based governance, which is always interesting when we get to the standardization. But the real question here is, it doesn't matter who it reports to. And again, I don't really care either. But there are 6 or 7 things that really need to be there for it to work. So number one, clear lines of authority. Having a clear line ensures that whoever's in charge of it has decision-making capability, can do policy enforcement, and can do risk management concerns around the medical device security. So you've got to have clear lines of authority, no matter where it reports. Accountability, strong communication, somebody who can, again, bring that collaboration, right? It's not one person's job. This is not siloed. This is all of our jobs. So really around that, wherever it reports, standardization, that's where that service line governance gets a little weird, because sometimes they don't get along with their neighbors, we'll just say. Then that same governance location reporting has to have that continuous improvement methodology. And above all, and this is why sometimes you see that hybrid or that centralized model come to play more, is alignment with organizational goals. Are we all pulling the same direction? And I think that's something that Sam said. Are we pulling the same direction? So clear lines of authority, accountability, communication, collaboration, standardization, always continuous improvement, and alignment with organizational goals. It doesn't matter who it reports to if you've got those.
Very good. No responsibility without authority, right? We don't want anything like that
100%.
going on. Ty?
Well, I guess I'd say Sam ×3, Jason ×2.
Sam wins. Sam wins. Okay, go ahead.
Just because I went first.
Exactly. Yeah, so not a lot to add. I would suggest, some of the things we've seen. There are a lot of hospitals that are contemplating moving clinical engineering, HTM, over into report under IT, working alongside of security. We see that a lot. There are organizations that take components of that and say, okay, well, these aspects will be managed because they're more similar. But in that case, you really need to make sure you're defining who has authority, accountability, responsibility, who should be consented, who should be informed. So maybe the RACI approach, so that no one is finger pointing. I would also throw out, having a committee, making sure there's a committee that has ISIT, clinical representation, compliance representation, and having the leader of that committee to be really the bridge or the translator between. So like Sam's incredible, right? For anybody who has had the opportunity to work with Sam previously, luckily I have. She has the ability to speak in kind of the different languages of security and clinical engineering and IT, which allows others in those different departments to understand why the operations have to be considered, why clinical engineering is doing something the way they're doing it. And then IT goes, oh, okay, in that case, I understand that, and we'll make adjustments. So I think that, if you have one, if you don't, you need to build one internally.
All right, very good. Brett?
I really liked what Jason had to say about aligning the security risks with the overall risk governance of the organization. I think that's a really great way of focusing what the organization is doing on what the broader organization wants to do. Because when you look at it, a lot of times you've got these two disparate groups, right? IT security and biomed/clinical engineering, and there's a gap there. And what we really need to do is bring those two knowledge sets together. And one of the really effective ways that I've seen to do that is to create a dedicated medical device security group. Then you've got people working together who have the clinical engineering background and who have the IT security background together in one group, and they're responsible for ensuring the security of those medical devices. You know, we are a medical device manufacturer. We provide services. We provide secure medical device security services. That is another route to go for particularly organizations who don't feel like they have the capabilities to implement this kind of thing. Leverage your suppliers to be able to provide those services that you may not have in-house. That's another option. And then recently an idea came up on a panel that I was on to rotate clinical engineering and IT security on like a 3 or 6 month rotation in the other group. That way they can get an idea and understanding and knowledge of what it means to control security risk or to, you know, have to support the clinical workflows of that department. That could be a really great way to bring those groups together and to create that knowledge internally. I think Sam and Jason both mentioned that a lot of these groups are moving under IT. I think that's a really great place for medical device security to sit, because when IT security owns the topic, they're really pushing that as the focus of the program, versus potentially when clinical engineering is, you know, it's sitting under clinical engineering, the focus is going to be on that clinical care process and not disrupting the process and keeping things the way they are. And sometimes you need that disruption to say, okay, you know, that procedure is working fine right now from a clinical perspective, but it's not working from a security perspective. So how can we change this so that security is satisfied and the clinicians are satisfied?
Brett, you mentioned before that security can't get in the way.
Right.
So, you know, that's the tough call, right? What takes primary priority? Security can't get in the way, but security's got to be taken care of somehow. So what are your thoughts there a little more?
Security can't be a blocker, but a lot of times security is going to drive changes in those clinical workflows, right? It may not make sense to have a rotating series of technicians who are all using the same account and they're just walking up to each machine and they're checking on it, and then the next person's coming up and they're checking on it and then they're using the same account. Yeah, that is what was done historically in a lot of places, and maybe there weren't even accounts on these systems. But we live in a different world now, and so how can you change that workflow so that you've got, you know, you're able to identify the employee that's performing the exam, that you know who's logging in, that you have tracking and logging, without disrupting the overall ability to perform those procedures.
Jason, that's always a tough conversation, right? When you're
I want to comment on this one.
Go ahead.
And again, hashtag be like Sam. So she said it, cybersecurity is patient safety. Okay. So when we say things like security as a blocker, security needs to be frictionless. Security is this sort of extra thing. It's not. You cannot perform the function of modern healthcare going forward without security and IT and those infrastructure components in place. You just can't. So, I mean, I think words mean things here. So I wouldn't say security is a blocker. Security needs to be, not in the way of it. Security needs to be self-evident. We do this. The reason why you have to have strong authentication, the reason why you have to have encryption and monitoring and risk management on medical devices is because if the threat actor, the bad guy, gets in and does something to it, it could have a kinetic real-world impact like that. It's patient safety. It's one of the three legs of the stool that the delivery of whatever that modality is delivering in the clinical environment or to the patient, it's part of it. And so I think that's also a cultural and language change we need to instill in folks, that I can't have this as something separate. It's not, because it's part of the DNA and needs to be part of the DNA of all solutions we're deploying now. So cybersecurity is patient safety, is patient care in a lot of cases, because it allows you to deliver that. Now, do it as frictionless as possible. But the only way you do that is by making it self-evident from the beginning.
That's such a great point,
Jason,
Jason. Go ahead, Brett.
I really like what you're saying. And I think that is like the North Star that we want to get to, right? That people aren't thinking about security as being separate, something separate, that it is part of that patient safety topic in general. I guess I just don't feel like we're there yet. And so in this transitionary process where, like, culturally we're moving towards it not being a separate topic, we still need to talk about security and clinical workflows and how we bring those things together.
Well, and Brett, let me just say that probably goes back to the governance conversation we're having, right? Systems that have good governance and bring all these multidisciplinary groups together have the conversations that Jason's talking about, right? It's not about one group pitted against another group, right? It's all of us, again, pulling together. And so having conversations with clinicians so that they understand what risk is, right? We're all aware on this panel that healthcare is the #1 targeted industry, right, for cyber threat actors. And so we all know this is a problem. We all need to be having these conversations across our entire ecosystem with clinicians, with physicians, with our C-suites, with our boards, to go ahead and educate them and help them understand that security is not a blocking department anymore. It's an enabling department. And what it's truly going to enable us to do is perform healthcare. Right? If we don't have appropriate cybersecurity departments helping to protect us, right, we are going to be shut down. We are not going to be able to provide care, right? We're going to be shuffling all of our patients from our ED to somebody else's ED because we've succumbed to some kind of cyber attack. And so, again, great governance, right, and understanding the North Star, to your point, is really where we need to start from, right, to get all of our organizations on the same page with Jason's thoughts.
And I think this is absolutely right on. So when you're having that conversation with a clinician or a clinical group, and you're talking about workflow that needs to be changed, and you're getting that pushback that this is somehow, or used to be, inviolate, right? Workflow is workflow. You work around the workflow. You don't disrupt the workflow. Well, that's over. To Jason's point, to your point, Sam, that's over, because your workflow, and perhaps in the scenario we're describing, your workflow is built on sand, okay, from a security point of view, and it cannot continue as such. Ty, makes sense, right? I mean, this is the new approach. Workflow is not inviolate. It's not sacred if it's not secure.
Correct. I would agree with everything. I would default to Sam and Jason. They're so close. They're living it every day. And I think the workflows that are impacted that we deal with are related to applying the security and how we can do that without with the least amount of impact.
Right. Jason mentioned frictionless, right? So we got to get there. Things have to be, to a certain level, but let's do it in the least with the least friction we can. So this is really Really good stuff. Really good stuff. Want to change topics a little bit. And Brett, let me bring you in first here. What's the relationship between device utilization management and risk?
And I think that utilization can be a great tool to reduce risk. Every organization that I've looked at has a large number of devices that are underutilized or not utilized. And right there, we're looking at risk that's sitting on your network that doesn't have to be. So like as an example, we see infusion pumps as being one of the highest risk categories of devices. And hospitals typically have way too many of them. If you don't have utilization data, departments are typically asking to buy more or rent more and more. But once you have that utilization data, you can reduce your fleet of devices and reduce your risk from those devices. So like, let's say you've got only 60% utilization of your infusion pumps. Now you can get rid of those leases or get rid of those devices, save a bunch of money, and reduce the risk from all of those devices which were probably vulnerable on your network in the first place. The other example I like to use is with larger devices. Let's say you've got 5 MRI machines, they're all running, Windows XP and Windows 7. Those are going to be inherently vulnerable. And let's say you only need 3 of them, and you know that from the utilization data. Now you can decommission those 2 devices, eliminating those risks entirely. You're saving money on the maintenance of those devices. Maybe you can even resell the 2 and then use those funds to upgrade the other devices. So now you've got an up-to-date fleet with fewer devices and fewer risk overall to your organization.
That's good. That's a good approach. Sam, utilization management, this is, and Jason will touch on this, but Sam first, a huge trend in IT is application rationalization, right? We want to get rid, we got 5 of that kind of do the same thing. Let's get rid of 3 or 4 of them. We save money, we reduce our security exposure. It's the same thing here with the devices, right? So what are your thoughts?
No, Brett hit the nail on the head, right? So if you look at it from a pure finance perspective, right, there are reasons to look at device utilization so that you can minimize the risk. Jason said the word a couple of times, right? Standardization is the key in healthcare, especially for him and I that have multi-hospital systems that I'm sure we've acquired over the years, and they've got various vintages of all kinds of different makes and models of stuff, and the standardization not only helps you from a utilization perspective, but also from a risk management perspective, right? So when we went through COVID, right, we had hospitals that were busy and we had hospitals that weren't busy, and being able to move devices from one hospital to another, right, to manage the patient population is incredibly helpful. But if those devices aren't standard, right, and they are unutilized, you can't transfer them, because then you got to train the staff, and then you got to figure out, where we're getting disposables from, and there's a whole host of other issues that you've got to overcome. So I would say even before we get to device utilization and reducing risk, I would start with standardization, right? And as you go through your standardization exercises, you can look at your device utilization and determine, can you downsize? I will say, right, to Brett's comments, we always have to balance the device utilization with what our community needs are, right? We all do community needs assessments, and we do want to ensure that patients aren't driving an hour to get a service. And so sometimes those underutilized MRIs that sit in the middle of my rural hospital that is definitely not utilized 60% of the time is a good choice to have. And so, right, I would agree with Brett. I would balance that with where healthcare needs to happen, especially in our rural communities, to ensure that we're meeting our patients' needs.
And you just want to
absolutely.
Go ahead, Brett.
I would say
Yeah,
you always have to look at the environment that you're working in, and you can't ever just say, oh, we've got 30% utilization, we've got 50% utilization, let's slash all of these devices. You've got to talk with those groups, you've got to understand why they have those devices. They may not know they have those devices, or they may, right? They may have those extra devices because of burst utilization, or they need it in a particular area and they can't share it or something like that. So yeah, definitely to Sam's point, it's not something you can do in a vacuum. You have to be talking with those groups to really understand why the usage is the way it is and what the need is.
Can I jump in? So
Yep.
one of the things that we have 2,000 hospitals using our technology, 7 million devices that we're protecting and monitoring. So we really understand this, and part of the way that you accomplish this utilization is through a technology we use called deep packet inspection. It's a different approach, a lot more work up front, but it provides us the ability to see into the packets of information that are going across the network. This is the passive monitoring that Brett was talking about. But in that cybersecurity data is also utilization data. And it's never been seen before, really. And just to kind of take it home as an example, because just this last week I was traveling with a cybersecurity director for Ascension Health, 139 hospitals, 124,000 medical devices in their network. And they had this fiscal year, so there's a few months into this fiscal year, had projected they were going to save $4.8 million in savings from reduction in devices they think they had 900 million to replace the ones they needed to. So they're really just going to try to reduce those that really need to go, that they're not necessarily using enough. And so they are already at $7 million in savings, and now projecting $20 million in savings the first year. This will be ongoing. And those were the numbers that they were sharing as we were traveling and doing presentations. So these are real numbers. They are big numbers. And a lot of it comes from that deep packet inspection.
Very good. Jason, what are your thoughts around, and it's a great point. You may not decide to shut something off for certain reasons, but at least you want to know, right?
Yeah, 100%. I think device utilization management and risk are completely interrelated in a healthcare setting. I kind of top two items for me: identifying risks and mitigating risks, right? So identifying risks, using device utilization management, we're going to understand what's the effective utilization of these devices. For instance, how are they being used, by whom, what purposes? And that's critical for identifying potential risks associated with device misuse, unauthorized access, or improper handling. So if you can watch the utilization data and understand, like, hey, that's really weird that this MRI is acting this way at this time of night on this particular days of the month, which rolls into those things like I'm talking about. When you understand device utilization, you can spot things like abnormal usage patterns, potential sources of vulnerability, areas where security controls may be lacking that you thought you had there. And so that kind of rolls into, again, the mitigation of risk. And we talked a little bit about optimal allocation. So utilization management really ensures that medical devices are allocated and used optimally, reducing the risk of things like overuse or underuse in the organization when supporting our populations, patient populations, which 100% could lead to safety issues or operational inefficiencies, if nothing else. And the risk mitigation that comes out of something like that, when you look at it, you can, for instance, limit access to certain devices to authorized personnel only. And that can mitigate the risk of unauthorized use. And this, not to plug Medigate, but we have it. We have it deployed here at MultiCare. And recently, I had a third party that had a security event. However, they were delivering a modality to us in a remote fashion that was essential to clinical operations. What we're able to do, and this goes to kind of that deep packet inspection that Ty mentioned there, we're able to say, hey, I know that this device, in order to maintain the clinical modality that this is providing for us, this device needs to talk to this system only in our network. And so during the event, we're saying, okay, we can sever this connection out here with a third party. So there's no sort of chance of ingress of a threat actor there. But how do we now maintain that internally just in case there was something wrong? I'm able to go in, look at it and say, these devices, boom, and that's going to immediately provide the continuity of care. A lot of times I think our jobs here is continuity by design, not security or privacy or compliance by design. Continuity, business continuity by design. So how are we're able to take that and then isolate and provide the control around it until we had an all clear on that. But the good part, the sort of the side benefit of that, mitigating that risk, is when we kind of turn that back on, we kept that segmentation. So now we know that's all it needs to be, and it works, and it is much more secure. And that's that idea of frictionless security now, right? Only authorized people, only the authorized systems. So even when we were sort of event horizon passed from the active threat, we now, out of that, we're net more secure, less risky as an organization. So I think they're intertwined.
That was a very good story. Very interesting anecdote there. All right, let's go to our Ask a Co-Panelist section. Ty, I want to give you an opportunity to ask one or more of your co-panelists a question.
Okay, wonderful. Well, what I think would be great for the listeners is if Sam, could you talk a little bit about your role at HSCC and some of the free publications that are available for individuals on the topics that we have? I had the luxury of being on some of your work groups, and I think everyone would benefit from knowing about those documents.
Sure. So medical device security and governance, right, are topics that there are a lot of resources out there for. And I know there are some health systems that struggle because they don't have the appropriate staffing or resources to go ahead and really dig into topics like this and really get their arms around it. So to Ty's point, I'm going to advocate for a group. It's called the Health Sector Coordinating Council at healthsector.org. And it's the public-private partnership between the U.S. government and all of the health sector, our manufacturing friends, right? Those of us in actual healthcare, the insurers, you name it. And they put out guidance for you. And it is literal, helpful documents that tell you how to. It's not high level, well, maybe you should do it this way, or maybe you can implement this. It's very detailed guidance as to how to help mitigate your risk. And so we actually last year published a medical device legacy document that tells you how to secure your legacy medical devices and minimize your risk around those. There are documents out there around governance. There's supply chain risk management out there for everything else. And then the premier document that they published a couple years ago and just updated this year is called the HICCUP, which is the healthcare practices document. And so if you need help, right, and you have nowhere to start and you have no people to go look for stuff, start at healthsector.org. And they have a list of documents that are very useful for you to start implementing security controls and understanding what your risks are and mitigating those risks in a very low-resourced kind of environment.
Excellent. That was a great question, Ty. So thank you for that. Brett, how about you? You have a question for one or both of your co-panelists?
Yeah, I was going to ask Sam a question too. I hope that's okay that we're not just all putting you on the
All right.
spot
We'll get
here.
Jason in soon. We'll get Jason in. Sam's very
I'm going to
popular.
ask Sam questions
Jason.
also, so it's all right.
She's very popular. Okay. Go ahead, Brett.
I know that, so you've talked about your clinical engineering background. I saw that has been your career history for the most part. How did you get into security? What did you do to ramp up your knowledge and your capabilities on the security side?
Yeah, so funny enough, years ago in a previous health system, it was actually an audit finding, right? That our IT department didn't have a robust enough medical device security program. And so they came and tapped on my shoulder and said, we know nothing about medical devices, right? And we have this audit finding that we need help with. And so ultimately, right, I knew enough to be crazy dangerous. And so you continue to go out there and learn, right? I hate to say we all need to continue learning and growing as especially as cyber threats continue to change our landscape dramatically. And so, right, I went out and started studying, trying to understand exactly what their regulatory burden looked like, where the audit finding was coming from, what minimum security standards were, what controls needed to be put in place. And ultimately, I think I found it doesn't necessarily differ, right? Whether you're an IT person or whether you're a clinical engineer, whether you're a facilities individual, right? If you can get to a mentality around risk management, we're just managing different risks that are called different things, but fundamentally they're all the same thing, right? And we need to, somebody said it earlier, right? We need to talk each other's language to really understand, right, what we're doing internal to our departments, what we're doing outside of our departments across the enterprise to mitigate those risks. And so, you know, there are programs out there. Amy has an educational seminar to teach clinical engineers about security. There's all kinds of certifications out there that individuals can go gain to learn more about healthcare if you want to get into healthcare cybersecurity. Fundamentally, it's just about growing and developing and applying what you know to an area adjacent to where you are. Jason, I'm sure you've had a very similar experience learning about medical devices, right? They weren't a thing 20 years ago.
Gosh, you know, and you're vectoring towards where my question around this, or my ask a co-panelist was, which is going to be more of a shotgun approach. I'll ask co-panelists on this one. So I've been dedicated to information security in healthcare probably the last 13 years now, 12, 13 years specifically in healthcare for that environment. And even in that, which I would consider a short period of time, the threat landscape has shifted dramatically. And one of the things that came up, and that's been coming up over here, still comes up today, is, hey, that's a legacy device. Hey, it's 510K certified, so I'm not going to touch it. I don't care how much of a risk it is to you. And there's just like been this little shield that's sort of around things like, that sounds not convenient to me. I don't think I'm going to provide you a solution. So go secure yourself. And I get that. I have received that over the years from medical device manufacturers. It's like, hey, security is not my thing. Patient clinical care modality is my thing. So you go do your thing, and I'm not going to do your thing. And so it's interesting to see things that are our technology, not classic IT technology, but they are technology, sort of not have that, or not be willing to shift, not be willing to shift. And medical devices in the past, not so now, right? But if I'm just looking over the last decade or so, I've been like, nope, I got my piece of paper here, says I don't have to do anything. You can't change anything. I don't have to. And slowly it's those federal mandates and organization like Sam's and mine that are saying, hey, no, we need you to play your part. We need you to play your part in this risk profile that's here around medical devices, because they are their own unique thing, but we need to fold them into the standardized thing. You can be uniquely standardized, specifically ambiguous. I don't know what your term is for it, but you're going to have to help us find a way to wrap that. Again, microsegmentation. How close can I bring that security perimeter around, not touching or impacting with the medical devices, yet still providing risk reduction organizationally? And I think, we've mentioned it again, a couple of themes. That's a culture theme too. That's a culture. Nope, I'm just here to do this one thing. Well, this now needs to be part of your one thing.
Mm-hmm.
And I think folding some of that stuff with medical devices, like I said, it's way different than like, I'm going to replace that laptop. I'm going to update this switch. I'm going to get a faster internet pipe. I'm going to consider AI down the road. I mean, all these, it's different than that, because these are things that directly impact patient care. I mean, directly, and that means kinetic event possibility. So, so all of that, how organizationally you're handling things, and I mentioned my favorite friend there, 510 can certify things. I can't touch this. I'm not going to touch this. I'm not going to update this. How are you mitigating those risks in the organization? I'll throw it to Sam first. Like the devices that like, no, I refuse to move that. The giant MRI. Yes, I know it's running Windows XP embedded. We're not going to do anything to it. So what's your approach there?
Yeah, we use a lot of compensating controls, right? So fundamentally, right, and I said it earlier on, right? We look at risk at an enterprise level. So first off, is it internet connected, right? And so if I have a device that's internet connected that's legacy that I can't do anything with, that's a huge red flag for us. And we try and figure out, does it have to be internet facing? Can we reduce the risk by pulling it inside and right, not having it face the internet? Or can we put multi-factor in front of it, right? We look at all kinds of varied other risk mitigation tools or techniques to go ahead and try and mitigate whatever risk that is. And then ultimately, if the risk is still too high, the answer is to replace it, right? You have to advocate for replacing that technology with newer and updated technology if the risk is too big for your organization. So at least that's what I'll say.
All right, we are almost out of time, so I want to give everybody an opportunity for what we'll call somewhat of a lightning round of final thoughts. Let's say 30 seconds, something like that. Ty, let's start with you. Your best piece of advice for a healthcare IT security professional listening to this and sort of trying to get their arms around this problem. What's your best piece of advice?
Well, it's the same piece of advice that Gartner is giving. Gartner is saying, go out and find a tool like Medigate and some others and have a Pepsi challenge, put them on your network, and let's see what it is that you're not seeing. On their continuum of care, where they say what the different stages are in fixing the cyber physical problem. The third step is, oh, wow, because everybody comes to that moment where they're, oh my gosh, I didn't realize I had all these things on my network. So find out which one works best for you and find out, show yourself that you're not getting the visibility that you need to actually take care of this problem.
Great stuff. Great stuff. Jason, your final thought.
Okay, I've got two. So number one, like we talked about, develop a robust governance structure. So if you don't have it, start today. Establish a clear governance structure that promotes cross-departmental collaboration among IT security, clinical engineering teams, and the greater clinical care teams and risk at the organizational level. There needs to be a clear line of authority, accountability, and communication regarding medical device security, because they are us, we are them. And the second item on there would be invest in that culture change too. So that's investing in education and training. So continually educate and train your staff on latest cybersecurity best practices, regulations, technologies, but also create awareness about the potential risks associated with medical devices and help promote a culture of security in that thought space as well. Those are my two.
Excellent, Jason. Sam?
Yeah, I double down on what Jason said, and then right in that culture, I would just get them to live cybersecurity is patient safety, right? If every one of your clinicians can say cybersecurity is patient safety, right, you have won the war.
Excellent. And Brett, we'll give you the last word.
Thank you. I guess, first of all, I would just say, just start. You know, in your organization where you might be able to start pulling these levers to improve medical device security. Maybe it's purchasing tool, maybe it's bringing an organization together, maybe it's changing the culture, but nothing's going to improve if you don't start now, and now is the best time to start. And secondly, utilize your suppliers. We have deep expertise and we're ready to help you right now.
Awesome. Yeah, managed services, any kind of outside help is big, very big in cybersecurity these days. You can't do it on your own. Regarding, that's about all we had time for today. Regarding continuing education, you could use the last slide in this deck. You'll get an email when the on-demand recording is ready for viewing. If you want to sponsor an event with us, you can reach out to Nancy Wilcox from our team and go to our website to register for upcoming panels. With that, I want to thank our tremendous panel, Sam Jacques, Jason Elrod, Brett Harris, and Ty Greenhalgh. I want to thank Siemens Healthineers and Medigate by Claroty for sponsoring and making it possible, and you for attending. And with that, everybody have a wonderful day. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.